Chapter 31, bleeding. Going to get into a lot of shock here. So chapter 31, let's get this thing started. So our introduction, A before B, except after C. So in trauma care, we've traditionally focused on airway and breathing as the first steps in treatment. However, when severe bleeding is involved, then this priority will shift. So why focus on circulation first? Well, bleeding is time sensitive. So uncontrolled bleeding can cause rapid deterioration, so stopping it immediately is going to be critical. By doing that, we're protecting perfusion. So controlling bleeding ensures oxygen continues to reach those vital organs. So when does this CAB take priority? CAB takes priority when massive hemorrhage is present or suspected. Circulation becomes the top priority, followed by airway and breathing. So by addressing these life-threatening bleeding first, we improve the patient's chances of survival. Now, this shift in priorities highlights the importance of adapting to the situation. Sometimes stopping the bleed comes before managing the airway. And now, circulation and bleeding. Circulation is essential for effective airway management. Even the most skilled airway management won't help if there's not enough blood circulating to carry the O2 to the tissues. So don't underestimate bleeding. Small bleeds can escalate. Minor bleeding might seem harmless at first, but can quickly become a serious problem if it's not managed appropriately. And then watch for early warning signs. So symptoms like general weakness might be the first hint of trouble, and if ignored, they can progress to shock. So always prioritize addressing circulation and controlling bleeding early. Stopping blood loss is a critical step in effective and successful patient care. So let's talk a little bit about anatomy and physiology of the cardiovascular system, so the heart and circulation. Now, the right side of the heart, think of this as the lung team. Its job is to pump blood to the lungs, where the blood picks up oxygen and gets rid of carbon dioxide. And then the left side of the heart, that's the body team. So it pumps the oxygen-rich blood from the lungs to the rest of the body, making sure that the tissues get the oxygen and nutrients that they need to work properly. So kind of a simple breakdown, that heart, as we know, it functions as a double pump. One side focuses on the lungs, which is the right side. One side focuses on the body, which is the left side. This coordinated system keeps oxygen flowing exactly where it's needed. Now, the role of lungs and tissues in circulation. So the lungs, might think gas exchange hub is what we're talking about. Blood arrives at the lungs loaded with waste gases like carbon dioxide. In the lungs, this waste is removed and fresh oxygen is picked up, getting the blood ready to fuel the rest of the body. And then at the peripheral tissues, you have kind of the exchange reversal. So blood reaches the body's tissue and the process switches. Oxygen is delivered to the cells to keep them alive and functioning. And then waste products like carbon dioxide are collected for the return trip back to the lungs. So think of it like a delivery and pickup service. Oxygen is delivered to keep the body system powered, and then waste is picked up to keep the system clean. This constant exchange keeps the body working smoothly. Now, what happens when that blood flow is disrupted? So there are some consequences of stopping or slowing blood flow. A few of those are waste buildup. Cells can't get rid of enough waste products like carbon dioxide, so they start to pile up. You have oxygen disruption, so oxygen delivery to tissues is interrupted, leaving cells without the energy that they need to function. You have the anaerobic switch, so you should remember anaerobic versus aerobic metabolism. So without oxygen, cells switch to anaerobic metabolism. So you can kind of think of that like turning on a backup generator. It keeps it going temporarily, but it's less efficient and creates harmful byproducts like lactic acid. Now, we get into rapid cell death. Within just minutes of no blood flow, cells begin to die, which is why quick action during circulatory failure is so critical. And then the body's survival strategy. So there's lots of these mechanisms within the body. So to protect itself, the body prioritizes blood flow to the brain and the heart. Remember, this is a survival strategy, so it's not optimal, but it's a survival strategy. It keeps vital organs functioning, but may reduce blood supply to other areas like the skin or the digestive system. So your body fights to protect the essentials, your brain and your heart, but it's a race against time. Restoring full blood flow quickly is crucial to prevent permanent damage. shows you a picture of kind of your circulatory system. Requires 3 intact components to keep those blood moving through the body. You got the pumps, you got the pipes, you got the fluid. Now the cardiac cycle. Let's break it down. So we have the basics of the cardiac cycle. So think of the cardiac cycle as the heart's rhythm. It's the repeating process of the heart filling with blood and then pumping it out to the body. So a couple terms we're going to need to get familiar with. Preload, getting ready to pump. So what it is preload is the amount of blood returning to the heart ready to be pumped out. So a simple analogy, picture a water balloon being filled. Preload is how much water or blood in the body is coming into the balloon or the heart before you squeeze it. Now afterload, that's kind of the resistance to pumping. So what is afterload? It's the pressure in the aorta or the resistance in the arteries that the heart must push against to pump blood out. The higher the afterload, the harder the work. So if the arteries are tight or blocked, the heart has to work much harder to move the blood. Now, what happens to stroke volume? Stroke volume is the amount of blood pumped out with each heartbeat. If the afterload is high, it's like trying to blow up a balloon that's already tight. The heart pumps out less blood, so the stroke volume decreases. So just a little quick refresher. Preload, how much blood fills the heart before it pumps. Afterload, the resistance the heart must overcome to pump that blood out. So balancing preload and afterload is going to be really important here for the heart to function efficiently. Now, cardiac output, understanding it and its influences. Now, when we talk about cardiac output, we're really talking about the heart's productivity. So the definition of cardiac output is the total amount of blood the heart pumps in 1 minute. The formula for that is cardiac output equals stroke volume times the heart rate. So it's expressed in liters per minute. And then anything that affects the stroke volume, so how much blood is pumped per beat, or the heart rate, will directly impact cardiac output. This directly influences how well oxygen is delivered to tissues, or what we've talked about already is that perfusion. So how does venous return impact the heart? Well, venous return is the amount of blood returning to the heart from the veins. Now, within that stretching those ventricles, when we're talking about the contraction, more blood returning equals more stretching of the ventricles. This triggers a stronger contraction, pumping more blood out. So we can talk about the Frank-Starling mechanism or Starling's law. So think about a rubber band. The more you stretch that rubber band, the harder it snaps back. So similarly, the heart contracts more forcefully when it fills with blood, but that is up to a limit. So cardiac output is the heart's performance measure driven by stroke volume, heart rate, and venous return. And then with that Frank-Starling mechanism, that ensures the heart adjusts its pumping force based on how full it gets, maintaining balance and efficiency. Now, ejection fraction and cardiac adaptation. So really when we're talking about ejection fraction, we're really talking about the heart's efficiency. So the definition of that is ejection fraction is the percentage of blood the heart pumps out of the ventricles with each contraction. So a healthy heart keeps ejection fraction stable even when the amount of blood returning to the heart fluctuates. Now, something to think about is ejection fraction shows how well the heart adapts to meeting the body's needs without losing efficiency because it's able to make some changes in there. So adapting to increased blood return. Now, when more blood returns to the right atrium, the heart pumps harder to handle the increased volume. The result of that is a greater volume of blood is pumped out with each contraction. However, the ejection fraction remains constant despite the extra workload. Now, why is that? The heart adjusts its force based on demand, not by the changing of the proportion of blood that it pumps. It does make some automatic adjustments in there. So the heart naturally adapts to small changes in blood volume caused by just a couple things. Position changes, moving from lying down to standing up, or even coughing can do that, a sudden increase in pressure inside the chest, so interthoracic pressure. So we mentioned it before, but a healthy heart is efficient and flexible, pumps harder when more blood returns, keeping the ejection fraction stable and maintaining normal function under different conditions. Blood and its components. So the blood overview, blood's made up of two main parts, plasma, the liquid portion, formed elements, the cells and cell fragments suspended in plasma. Now, plasma is 55% of the blood volume. The definition of plasma is the liquid part of blood, mostly water, containing dissolved proteins, nutrients, hormones, and waste products. What its role is it acts as the delivery system, carrying cells and distributing vital substances throughout the body. So formed elements, now those are cells suspended in plasma. You have red blood cells, white blood cells, platelets. The percentage of red blood cells, about 45% of the blood volume. And what it does, it functions by transporting oxygen from the lungs to tissues and carrying carbon dioxide back to the lungs for exhalation. And then white blood cells, less than 1% of blood volume, defend against infections and aid in immune response. And then platelets, so they're less than 1% of blood volume, critical for clotting. They stop bleeding by forming clots. So blood's a highly specialized tissue that sustains life by transporting oxygen, nutrients, hormones, immune cells, also removes waste products, and then we mentioned that it supports clot formation to prevent excessive blood loss. And then the purpose of blood, so kind of the main functions of blood. Hopefully we already understand that, but blood carries oxygen from the lungs and vital nutrients from the digestive system to the body's tissues. This ensures cells have the energy and materials they need to function. And they also remove waste products. So blood picks up cellular waste such as carbon dioxide and other metabolic byproducts and delivers them to the lungs, kidneys, liver for elimination, keeping the body clean and functional. Now there are specialized functions of formed elements. So when we talk about white blood cells, we're talking about fighting infections. These are the body's defenders. So attacking bacteria, viruses, other harmful invaders to prevent illnesses. And then that we mentioned that it helps control bleeding within those platelets. Tiny fragments, they help form clots at the injury sites. They act like little plugs to stop bleeding and prevent excessive blood loss. So blood's the body's transportation and defense system. So it ensures that those tissues are nourished with O2 and nutrients, the waste is removed for disposal, infections are fought off, and bleeding is controlled to maintain stability. Now, plasma and platelets. So kind of the fluid components of blood. We're talking about plasma. Its appearance is watery and star-colored. Volume contribution makes up over half of the total blood volume. Now within its contribution or composition, you see 92% water, keeps blood keeps blood fluid and helps dissolve substances for transport. And then you have about 8% dissolved substances. So you get essential chemicals, minerals, nutrients. Those help to support the body's function. And then platelets, kind of the body's clotting heroes. What they are just a small disc-shaped cell fragment, essential for stopping bleeding. So their role in clot formation is those platelets work alongside clotting proteins, which are found in plasma to form clots. And then those proteins and calcium, they're needed to stabilize clots. And platelets gather at the injury sites to form a plug, preventing further blood loss. So plasma is the blood's transport medium, carrying nutrients, minerals, vital substances throughout the body. And then platelets partner with clotting proteins and calcium to form clots, ensuring injuries don't lead to excessive bleeding. Now, blood circulation and perfusion. Let's kind of compare and contrast arteries versus veins. So arteries carry oxygen-rich blood away from the heart to nourish the body. Veins transport oxygen-depleted blood back to the heart for reoxygenation in the lungs. Within there, we have diffusion, so that natural movement of substances from areas of higher concentration to areas of lower. So how it works within circulation is carbon dioxide and waste products leave cells and enter the capillaries. And then these byproducts are then transported through the bloodstream for elimination. Within perfusion now, talking about perfusion, we're talking about the delivery of blood to tissue and organs in amounts sufficient to meet their needs. So why is it important? If we're talking about perfusion all the time, why is it important? It ensures cell receives oxygens and nutrients. So removes carbon dioxide and waste products, maintaining healthy cell function. So kind of a takeaway, blood circulation delivers oxygen and nutrients to the body. Diffusion and perfusion work together to remove waste, ensuring tissues remain healthy and function optimally. Now the autonomic nervous system and blood flow. So the autonomic nervous system automatically regulates the blood flow to ensure the body's needs are met. It achieves balance through its two components. You have the sympathetic nervous system. So think that fight, flight, or freeze mode, and it's activated during stress or threats, internal or external even. Some of the key actions is in the heart, increases heart rate, and it strengthens contractions to pump more blood. The lungs promote rapid deep breathing and bronchodilation to maximize oxygen intake. Within blood flow, we see it directs blood to the vital organs like the heart and the brain, while reducing blood flow to the non-essential areas, so thinking about like skin, for example. And then digestion slows or halts to conserve energy for immediate survival needs. And then we have the parasympathetic nervous system, so you can think of that as kind of the rest and digest mode. It's activated when the body is calm and in recovery. So the heart slows, reducing the strain, the lungs breathing slow to a normal relaxed pace, digestion speeds up for processing those nutrients and absorption and repair. So kind of a takeaway, sympathetic nervous system helps the body respond to emergencies, prioritizing survival functions, while parasympathetic restores and repairs the body afterward, maintaining a healthy balance of vital processes. The vasomotor and blood pressure regulation. So we're talking about within the medulla oblongata. The vasomotor center is a key regulator of blood pressure, adjusting blood vessel tone based on signals from the body. Now, a response to low blood pressure, because this thing is responding, constantly make adjustments and little changes. So its response to low blood pressure, first, the baroreceptors in the blood vessels detect a drop in the pressure, so it detects that drop. It communicates that. These sensors send signals to the brain via the cranial nerves, as well as the brain then activates the sympathetic nervous system, causing vasoconstriction, so the blood vessels narrow or increasing pressure, and then increased heart rate and contractility. The heart pumps faster and harder, improving the blood flow. Now the response to high blood pressure, the process reverses. So the baroreceptors signal the brain to reduce sympathetic activity, the blood vessels relax or they vasodilate, and the heart slows down, lowering the pressure. Now there's an endocrine system role in blood pressure as well. So the endocrine system supports blood pressure regulation through hormone release. This is going to be important because we talk a lot about this within shock as well. Not a lot, but it has some pieces in shock. So the response to a drop in blood pressure, so you have aldosterone, which comes from the adrenal glands. It encourages sodium and water retention by the kidneys, increasing blood volume. If you remember why that would be important, because water follows sodium. And then you have ADH, or the antidiuretic hormone, comes from the pituitary gland. It reduces water loss through the kidneys, conserving blood volume. So these effects of the hormonal action is some vasoconstriction, so it tightens blood vessels to raise the pressure, and then water conservation also helps to maintain those fluid levels in the bloodstream, preventing further pressure drops. So the vasomotor center and the endocrine system work together to stabilize blood pressure. So by adjusting that vessel tone, heart activity, fluid balance, they ensure proper circulation and tissue perfusion, even when during changes in the body's needs. Now, when the cardiovascular system fails, so we're talking about hypoperfusion or shock. So hyperperfusion or shock occurs when the cardiovascular system fails to maintain proper circulation. This prevents those tissues from receiving the oxygen and nutrients that they need, leading to ischemia, or what you might think of as tissue damage. So there are some critical factors for oxygen delivery. Heart rate. Heart must beat at an appropriate rate to pump blood effectively. If the heart rate's too fast or too slow, circulation becomes inefficient. And now we get back to what we were talking about before, stroke volume. So this is the amount of blood the heart pumps out with each beat. Reduced stroke volume caused by factors like blood loss, weakened heart, or even increased resistance. All of those things limits blood flow. And then you have things like hemoglobin levels. So hemoglobin in red blood cells responsible for carrying O2. Low hemoglobin levels, so due to anemia or blood loss, reduce the blood's oxygen carrying capacity. And then arterial O2 saturation. So this measures the percentage of oxygen bound to hemoglobin in the blood. Low oxygen saturation, as seen in respiratory distress or even poor ventilation, decreases oxygen delivery to the tissues. Now, shock occurs when one or more of these critical factors is compromised, leading to inadequate oxygen delivery. So what's very important here is early recognition and prompt intervention are crucial to prevent irreversible damage to vital organs and tissues. Now, hemorrhaging. So hemorrhage, kind of talking about the hemorrhage let's define it. So it refers to bleeding, which can be either external or internal. So external is visible, often manageable on scene. Now, internal, though, makes it more challenging. It's hidden and typically requires surgical intervention. So controlling external hemorrhage, visible bleeding can often be managed effectively in the field using a few different methods. Direct pressure, so apply firm, consistent pressure directly over the wound to stop bleeding. Pressure dressings, secure a bandage tightly over the wound to maintain constant pressure. Splints, hemostatic dressings, those are impregnated with agents that promote clotting to control severe bleeding. And then tourniquets, so effective for severe bleeding in extremities when other methods fail. Put the tourniquet above the wound, proximal, and tighten until the bleeding stops. Now, managing internal hemorrhage, a little more complicated. Really not that complicated how we manage it, but it's more complicated for a patient. So internal bleeding cannot be controlled directly in the field and requires surgical care. So some of the things that we can do to help, though, is our assessment. So that assessment of the severity. Since the bleeding is not visible, we need to monitor for signs and symptoms such as rapid heart rate, maybe a low blood pressure, pale, cool, and clammy skin, abdominal distension or tenderness, and then, of course, decreased mental status. Now, these are going to be immediate transport patients, so they're going to be emergency-style patients. So patients with suspected internal hemorrhage need rapid transport to a facility capable of surgical interventions. And then extent and severity. So the amount and seriousness of external bleeding depend on the type of wound and the blood vessels involved. So let's look at a couple of different kinds of blood vessels and what they look like when we talk about the bleeding. So the appearance of capillary bleeding, slow oozing blood from small vessels, typically easily controlled with direct pressure. So venous bleeding, steady flow of dark red blood. It can be significant, especially if a large vein is injured. Arterial bleeding, bright red spurting blood that matches the heartbeat. So rapid and severe, when we talk about the severity, requires immediate control to prevent life-threatening blood loss or exsanguination. And then severe bleeding risk, so laceration or tearing of a large vessel that can lead to complete blood loss within minutes if not quickly controlled. Now, there are variations in bleeding, so some injuries may produce unexpected bleeding patterns based on specific factors. So like for a couple of examples here, an amputation with minimal bleeding. So in cases where heat, thinking about machinery or an explosion, it cauterizes the wound, bleeding may be unexpectedly minimal despite the severity of the injury. And then severe crush injuries, like thinking about a crushed leg or something, can cause extensive bleeding. So these injuries often require tourniquets, as a direct pressure may not be effective for controlling blood loss. So, really understanding these type of wounds and the blood vessels involved kind of helps predict the severity of bleeding and helps to determine the best intervention. So be prepared to adapt to unexpected bleeding patterns to minimize blood loss and improve our patient outcomes. And then internal hemorrhage, so causes in trauma. Internal bleeding can occur anywhere in the body as a result of trauma. These injuries can lead to a significant blood loss without obvious external signs, making diagnosis more challenging. Now, non-traumatic causes. Internal bleeding can also happen without direct trauma and may stem from various medical conditions. So we have GI bleeding, thinking about ulcers or varices, tears in the digestive tract. A ruptured ectopic pregnancy, which is a life-threatening bleed, occurs when a fertilized egg implants outside the uterus, commonly in a fallopian tube. And then a ruptured aneurysm, a rupture of a weakened blood vessel, such as an aortic aneurysm, can result in severe and potentially fatal bleeding. And then even certain cancers, blood clotting disorders, spontaneous ruptures of internal organs, all of those can lead to internal bleeding. So treating internal hemorrhage. So be proactive with our assessment. Internal bleeding might not be immediately obvious, so rely on the mechanism of injury, blunt trauma or high impact accidents, subtle clues to identify it early. And look for the warning signs. So pain and tenderness might report some discomfort in areas like the abdomen or chest, extremities even. Tachycardia, a rapid heart rate, is often an early indicator as the body compensates for blood loss. Pallor, pale or cool skin suggests reduced blood flow or oxygen delivery to the tissues, signaling potential internal bleeding. And then we want to make sure that we are monitoring for shock. So we want to look for some signs of shock. Altered mental status, so we're thinking confusion, restlessness, drowsiness. Weak pulses, of course, thready or barely palpable pulses. Low blood pressure. Now remember, a late sign of significant blood loss is low blood pressure or hypotension. So early recognition of shock is essential for initiating prompt intervention, such as rapid transport to a higher level of care. Okay, so understanding the impact of hemorrhage. Blood volume by gender. So adult males, approximately 70 mils of blood per kilogram of body weight, and then females, 65 mils of blood per kilogram of body weight. Now within each body, there is kind of a blood loss threshold. So the body can struggle to handle acute blood loss exceeding 20% of total blood volume. So for a typical adult, losing more than 1 liter of blood can significantly affect vital signs such as heart rate and blood pressure. Now within infants and children, because of their smaller total blood volume, even minor blood losses can have serious consequences. And then the rate of blood loss matters, so slower versus rapid bleeding. Slower bleeding gives the body time to activate compensatory mechanisms, so we're thinking about increased heart rate and vasoconstriction, delaying the onset of severe symptoms. And rapid bleeding, it overwhelms these mechanisms, causing vital signs to deteriorate much faster. And then recognizing serious bleeding. So be alert to serious bleeding when any of the following factors are present. A significant MOI or mechanism of injury, trauma or an incident with a high likelihood of causing substantial internal or external hemorrhage. So we're thinking about high impact collisions or even falls from height. Poor general appearance, so they appear visibly unwell or deteriorating rapidly, such as becoming pale, weak, or lethargic. And of course, signs and symptoms of shock. So low blood pressure, rapid pulse, pale, cool, clammy skin, confusion, altered mental status. Now, blood loss exceeding 20% of the total volumes, we mentioned it, that equates to approximately 1 liter of blood for an adult. For children, even smaller can have a lot of problems. So uncontrolled bleeding, we want to use direct pressure, maybe a pressure bandage or a tourniquet if things are that serious. So when any of these factors are identified, immediate intervention is essential. These signs indicate potentially life-threatening hemorrhage, requiring swift and decisive action to stabilize the patient. So the physiological responses to hemorrhage. Arterial bleeding, bright red, oxygen-rich blood, spurts in rhythm with heartbeat affecting the high pressure of the arterial system. That's probably going to be a little more difficult due to the arterial pressure in the way that we're going to manage it. So it requires direct pressure, maybe hemostatic agents, and often tourniquets for severe cases. Venous bleeding, steady and continuous, not pulse-like like arterial bleeding. Management is going to be usually a lot easier than that. We're talking about direct pressure, maybe a pressure dressing, as well as capillary bleeding, same thing, just some direct pressure. So venous and capillary bleeding characteristics. So venous and capillary bleeding clots more easily compared to arterial bleeding. Clots more easily compared to arterial bleeding. So this is due to lower pressure in veins and capillaries, which allows clots to form and stabilize more effectively. So kind of the time frame for stoppage, bleeding from veins and capillaries typically stops on its own within 10 minutes, provided there's no further disruption to the wound. Now, this natural clotting process often reduces the need for aggressive interventions in minor cases. You need to monitor these people, though. Even with natural clotting, continued observation is necessary to ensure that the bleeding is completely stopped and no clot dislodgement occurs, which could restart bleeding. Now, the steps of hemostasis. So the initial response, you get some vasoconstriction. So the blood vessels around the injury constrict, vasoconstriction, to reduce blood flow to the damaged area, minimizing blood loss. Then we start to get that formation of the plug, that platelet plug that we mentioned before. Platelets are drawn to the injury site, and then they clump together. They form a temporary barrier to slow the bleeding. And then we start to strengthen the clot now. So we get some fibrinogen activation. So it's converted into fibrin mesh formation. So the fibrin creates a mesh-like structure over the platelet, which you're kind of seeing in that picture. And over the platelet, the plug, the reinforcing and stabilizing the clot to seal the wound. And then clot formation requirements. So for bleeding to stop effectively, a stable clot must form. And then without a stable clot, bleeding will continue unless it's completely blocked or the wound is sealed off through external interventions. Now, when it fails, so medication interference, so anticoagulants or blood thinners, so medications like warfarin or aspirin can impair the body's ability to form clots by interfering with the clotting cascade. Beta blockers can certainly cause some problems, because these drugs can block vasoconstriction, which are a critical step in slowing blood flow at the injury site. And then the extent of injury. So it may be severe trauma. That injury may be so extensive that the clotting system cannot effectively seal the wound. And then partial vessel damage. So if only a part of the blood vessel is cut, it may not constrict properly, making it harder to reduce blood flow and form a clot. So within these things, kind of the outcome, in these cases, bleeding will continue until external measures are applied, such as direct pressure or tourniquets. And then hemophilia, a clotting disorder. So nature of the condition, hemophilia occurs when one or more clotting factors are missing, impairing the body's ability to form clots. You have a variety of forms. Most types are inherited, and they vary in severity from mild to life-threatening. Now, even minor injuries can become serious because the body cannot effectively stop bleeding, increasing the risk of significant blood loss. Now, the trauma triad of death. So what is a very dramatic title, but what is it? Now, the trauma triad of death is this very dangerous cycle involving three things with a triad. So the hypothermia, and then coagulopathy. So when we say hypothermia, hopefully you already know what I'm talking about, just cool body temps, or it can be external as well. Coagulopathy, impaired clotting, and then acidosis. Those are the three components. So they reinforce each other, and what they do is they create this rapid decline in trauma patients and significantly increase the risk of death. Now, I know what you're thinking. How does it happen? Good question. So within coagulopathy, what happens is the body's ability to form clots is impaired, leading to uncontrolled bleeding. What's the result of that, you might ask? Well, worsened blood loss can cause decreased blood flow or hypoperfusion to those tissues. And then acidosis. So hypoperfusion forces cells to rely on that anaerobic metabolism, producing lactic acid and other acidic components. Now, what happens is the result of that, these acids disrupt the body's normal systems, worsening the patient's condition. And then hypothermia. So reduced oxygen delivery and metabolism slow down bodily functions, leading to cold-induced clotting dysfunction. The result of that, hypothermia exacerbates coagulopathy, further impairing the body's ability to stop bleeding. So without intervention within this cycle, it leads to rapid deterioration and death. So each component amplifies the other, making it harder for the body to recover. So what do we do about that? Well, one thing we've learned, keeping patients warm. Preventing or addressing hypothermia is a critical step to breaking the cycle and improving outcomes. And then aggressive fluid and blood management. Ensure adequate perfusion while maintaining blood chemistry to prevent acidosis and coagulopathy. So like I mentioned, that trauma triad of death, or triad of, I don't know, whatever, is a lethal cycle that must be interrupted quickly. Warmth, proper fluid resuscitation, and rapid interventions to stop bleeding are essential to saving trauma patients. Now, we said aggressive fluid and blood management. Aggressive fluid does not mean running 1 or 2 liters wide open, which has happened in the past. We're not saying that. We're just talking about getting fluid going for the patient, as well as hopefully being able to administer blood products or get them to blood products. So shock, what is it? It's a life-threatening condition that occurs when the body's tissues do not receive enough oxygen and nutrients due to inadequate circulation. So there's a number of common causes. We got respiratory failure, so it can't deliver enough oxygen to the blood due to lung issues, so it might be respiratory arrest or even severe respiratory distress. We have pump failure. The heart is unable to pump blood effectively, reducing blood flow to vital organs, so cardiogenic shock from heart attacks or heart failure. We have poor blood vessel function, so blood vessels lose their ability to maintain proper pressure, causing inadequate circulation, so distributive shock, so sepsis, anaphylaxis, where vessels dilate excessively. And then low fluid volume, so insufficient blood or fluid levels in the body, they reduce blood pressure and circulation. So hypovolemic shock, shock from severe bleeding, or even dehydration. So understanding these causes is going to be pretty important for early recognition and effective treatment of shock. Identifying the root causes allows for targeted interventions to restore proper circulation and oxygen delivery to the tissues. Hypovolemic shock. So when the body loses vital fluids. So what causes hypovolemic shock? Well, it occurs when the body lacks enough fluid to maintain proper circulation and blood pressure. So fluids that may be lost include blood, plasma, electrolyte solutions, all of those things. Within hemorrhagic shock, the most common type of hypovolemic shock, caused specifically by significant blood loss, hemorrhagic shock. So we have a reduced blood volume, which limits the body's ability to circulate oxygen and nutrients. We know that without enough blood, tissues become ischemic and vital organs begin to fail. So prompt recognition is going to be really important with this. So, identification of signs like blood pressure, tachycardia, altered mental status, going to be really important. Fluid replacement, so replenishing those lost fluids, blood, plasma, electrolytes, essential to restore circulation and prevent irreversible damage. And then a big key takeaway, hypovolemic shock, it's a critical condition caused by blood loss or other vital fluids as well. So hemorrhagic shock, subtype, it's a kind of hypovolemic shock. It requires immediate attention to stop bleeding and replace fluids to sustain life. Now, hemorrhagic shock, so critical form of hypovolemic shock was what we've been talking about. Common causes, significant blood loss due to injuries that damage blood vessels. So we can see this when we start looking at blunt or penetrating trauma, injuries that tear or rupture blood vessels or even organs, fractures of long bones, major vascular damage, so thinking traumatic amputations, and then multi-system trauma, of course. So high-risk organs for blood loss. So certain organs and systems are particularly susceptible to life-threatening hemorrhage when injured. The heart, obviously, vital but vulnerable to penetrating trauma, which can cause rapid blood loss. Thoracic vascular system includes large vessels in the chest, so the aorta, pulmonary arteries, where damage can lead to catastrophic bleeding. Abdominal vascular system, so supplies critical blood flow to abdominal organs. Injuries here often cause rapid exsanguination. Remember, just bleeding out. All the stuff on the inside is now on the outside. And venous system. So damage to large veins can lead to significant blood pooling and reduced return to the heart. And then finally, the liver, highly vascularized, making it a frequent source of severe bleeding in abdominal trauma. Early intervention, early recognition, all of these things are going to be really important here. Now, some classifications for shock. So the American College of Surgeon Committees on Trauma categorizes hypovolemic shock due to hemorrhagic trauma into 4 classes based on the severity of blood loss and the body's ability to compensate. So compensated shock, 1 and 2, those key characteristics, the body activates compensatory mechanisms to maintain blood pressure and perfusion. So some of the things you might see is increased heart rate. You can see some narrowing pulse pressure. So when we say pulse pressure, we're talking about that difference between the systolic and the diastolic pressure. And then cool and clammy skin, and we should remember that that's caused by vasoconstriction. Now, with early interventions during this phase, the patient can stabilize and prevent progression to more severe shock. Remember, when we're talking about these shocks, we're wanting to kind of work ahead. We're trying to, if they're in class 1 or class 2, say they're in class 1, we're trying to not allow them to get to class 2, or as you see on your slide, stage 1, stage 2. Where the main thing we're trying to do is not allow them to continue on. So class 2, or we just did class 1 and 2. So class 3 is decompensated shock. So those compensatory mechanisms that we talked about, they begin to fail. They lead to severe circulatory compromise. So here we start to see is when you see a significant drop in blood pressure, poor perfusion of vital organs. So we're talking like brain and kidneys, mental status changes. So this stage requires immediate and aggressive treatment to restore circulation and prevent progression to irreversible shock. Now we get down to our fourth one, and we have irreversible shock, or class 4. The thing is, the key to that is that first word, that irreversible. So it's pretty serious, obviously. Prolonged and severe hypoperfusion results in cellular death, organ failure, and irreversible damage. So we start to see some profound hypotension, multi-organ dysfunction, so failure of the kidney, livers, and heart, or not the kidneys, liver, and heart. Extremely poor perfusion to the tissues. So survival is unlikely with these patients, even with advanced medical interventions, as the damage is just too severe for recovery. Now, this table shows estimated fluid and blood loss for a 154-pound patient. So when you start, or 70 kilos, when you start looking, you can see all the different stages, and the different changes within the stages, as well as the amount of blood loss. Progression of hypovolemic shock. So we got 4 stages of progression. We have our initial stage. So some of the key features of that: circulating blood volume decreases, but the body compensates effectively at first, so the symptoms may not be obvious. So you might see a little elevated pulse rate, but the blood pressure is pretty close to normal, or maybe just a little bit low. But minimal indications of hypoperfusion, making this stage hard to detect clinically. I mean, when you think hard to detect clinically, you think, well, they were just in a bad car crash, so I would expect their heart rate to be a little bit high. And you're right. However, it can also be something else. So the compensatory stage, what we just mentioned, tachycardia develops as the body works to maintain that cardiac output. Remember that cardiac output was heart rate times stroke volume. So when the stroke volume lowers, the heart rate has to go up to keep the same cardiac output. So hypotension can start to appear as blood volume continues to drop. You can see some early signs of poor tissue perfusion, such as delayed capillary refill, might become noticeable. As we get into our advanced compensatory stage, we see some tissue oxygenation issues. So oxygen delivery to tissues becomes critically impaired. Now within the cell, we're not going to notice this, but the cellular metabolism shifts into those anaerobic processes, leading to lactic acid buildup. So how that might present to us is our patient might have some increased confusion and anxiety from poor perfusion to the brain. They have some cold, mottled, pulseless extremities caused by heightened systemic vascular resistance as blood is shunted to those vital organs. And then worsening mental status. Remember, we're talking about that advanced compensatory stage now. And then decompensated. So decompensated shock. Without interventions, compensatory mechanisms fail, leading to widespread cellular damage, organ failure. The immediate treatment is essential to prevent progression to irreversible death with these patients. So we start looking at compensated versus decompensated shock here. Kind of some different things that we might see. Agitation versus, altered verbal to unresponsive status, sense of impending doom, weak, rapid, thready pulse, clammy skin, pallor versus ashen, mottled, or cyanotic, thready or absent. So lots of it just continues to escalate. Now, scene size up. So ensure scene safety, make sure everything is good, make sure it's safe there, make sure you got your PPE on. Be alert for high energy mechanisms of injury. So any incident involving significant energy transfer, so a high fall, maybe an explosion, motor vehicle crash, that increases the likelihood of internal bleeding or other severe injuries. You want to recognize your potential causes. So internal bleeding may stem from both traumatic injuries and underlying medical conditions. Maybe they were in a car crash and they had a GI bleed, or or a ectopic pregnancy, or a number of things. Gauge the blood loss, which can be kind of hard. Consider your visible blood loss, but prioritize the patient's overall clinical presentation. So when we say that, we're talking about vital signs, mental status. We're using that to help guide our care. Internal bleeding may not be evident, externally and requires vigilance for signs of hypoperfusion. And then with these patients, we want to monitor our scene time. We want to limit our scene time. So for patients with significant MOIs or suspected severe internal bleeding, aim to spend no more than 10 minutes on scene. So rapid transport to a facility capable of providing definitive care is crucial for survival. So it might not be just your local doc in a box or your local hospital, that you're 45 minutes outside the city. You may need to just go straight downtown with these patients. Of course, according to your local protocols. And then hemorrhage and life-threatening conditions. So we want to address that severe external hemorrhage first. So direct pressure and dressings, firm pressure directly over the wound, splints for associated fractures, tourniquets for hemorrhage that doesn't respond to direct pressure. Make sure you put a tourniquet on proximal to the wound. Hemostatic agents, maybe TXA. Maybe TXA is something that you have kind of within your toolbox there at your service. So consider TXA if the internal bleeding is suspected and the patient meets your criteria based on evidence and, of course, guess what? Your local protocols. And then manage your life-threatening ABC. So airway, obstructions, injuries, swelling, suction to clear everything out, breathing, chest wall injuries. So you want to assess for these injuries, these chest wall injuries. And we're talking about a flailed chest or a pneumothorax, and intervene as necessary. So we want to make sure we're providing lots of oxygen or ventilatory support if respiratory effort is inadequate. And then circulations, monitor for signs of severe blood loss or shock. So if we see weak pulses, rapid heart rate, those are kind of the things that we're looking for. Assess your skin, get your action plan, monitor your mental status, all of those kinds of things, your AVPU, all of that. And then rapid transport for internal hemorrhage. So when to suspect internal hemorrhage. Talk about some early warning signs almost. So tachycardia, early sign of hypoperfusion and possible internal bleeding. Remember, the body's compensating for that blood loss by increasing the heart rate. And then late indicator, so weakness, fainting, dizziness, thirst, nausea, vomiting, cold, clammy skin. Cold, clammy skin is a classic symptom of shock caused by vasoconstriction and poor circulation. Shallow, rapid breathing, dull eyes and sluggish pupillary response, delayed capillary refill, weak rapid pulse, failing blood pressure, altered LOC, kind of just goes on and on with all the things that we've talked about with kind of external injuries with shock. Shock is shock when it's working internally because it's still hypoperfusion. So once again, keep them warm, give them O2, transport, rapid transport. So the key steps in gathering a patient history: investigate the chief complaint, begin by identifying the primary reason a patient is seeking care. Maybe they were, having belly pain or no telling what's going on, but we want to find out the primary reason. Ask open-ended questions, ask targeted questions. So like dizziness or syncope. So look for signs of hypoperfusion or internal bleeding, such as fainting or lightheadedness. You definitely want to ask about what meds they're on. Are they on anticoagulants that could worsen the bleeding, beta blockers, or even calcium channel blockers, which can mask tachycardia, an early sign of shock, or antidysrhythmic drugs or nitro, which could affect blood pressure and perfusion. Then we talk about those history of clotting issues, which we talked about, the clotting disorders, and then pain or physical signs. So pain or tenderness, bruising, guarding, swelling. Swelling could suggest fluid retention, maybe some localized trauma. And then a secondary assessment. So perform a systematic full body exam. For unresponsive patients or those with a significant mechanism of injury, perform a head-to-toe assessment to quickly identify potential injuries, focusing on areas prone to internal bleeding. So thinking chest, abdomen, pelvis, those kind of things. So look for symptoms, pain and swelling, maybe some visible signs. You might see, some ecchymosis, some weird bruising patterns or contusions. You can see, think about like Cullen sign, which is bruising around the umbilicus, indicating abdominal abdominal bleeding, or even Gray-Turner sign. So bruising along the flanks, or often a sign of retroperitoneal bleeding. And then hemorrhage from body openings can signal internal bleeding, so bright red bleeding from the mouth or the rectum, hematuria, blood in the urine, often associated with kidney or bladder trauma, non-menstrual vaginal bleeding, which could indicate uterine or pelvic injury, and then observe the color and the amount and source of the bleeding to guide the targeted interventions. So kind of some other signs and symptoms of internal hemorrhage. So hematoma, localized swelling filled with blood, hemoptysis, melena, hematuria, so blood in the urine. You got black tarry stools, coughing up blood, hemoptysis, a lot of different things. Referred pain. So when we start talking about physical signs, obviously broken ribs, bruising over the lower chest, rigid distended abdomen may suggest a lacerated spleen or a liver injury. And then we have referred pain. So right shoulder pain may indicate a liver injury due to the irritation of the phrenic nerve. Left shoulder pain can indicate a spleen injury. Always suspect internal abdominal bleeding when referred shoulder pain is present. Now, steps for a systematic secondary assessment. So respiratory system evaluation, make sure the airway is clear and patent. You may need to use suction or an airway adjunct. Make sure when we talk about respirations, the rate and quality of breathing, is it shallow, is it rapid, are they labored? Looking for neck examinations, so for distended neck veins or even maybe a deviated trachea, which could signal thoracic injury or a tension pneumo. Cardiovascular system assessment, so a pulse check, looking at all the things that we know, rate, quality, those type of things. Of course, you want to get an ECG, pulse ox, and we've already talked a little bit about this, but I'll mention it again. So there is an impact of medications that the patient may be on. Beta blockers, they can mask tachycardia. Calcium channel blockers and nitro can limit vasoconstriction, reducing the body's compensatory ability, and then antidysrhythmics impair the heart's ability to compensate for stress. Now, we've mentioned this many times, but we'll go again. Patient presentation in shock. So pale, cool, or mottled skin, weaker absent radial pulses, delayed capillary refill. Maybe they have a level of consciousness change, either a AVPU thing or a GCS kind of thing. Pupil size and reactivity, we want to look for unequal or sluggish response. Within musculoskeletal system, deformities, tenderness, fractures. Now we know within the head we want to look for things like raccoon eyes, so that bruising around the eyes, often indicating a skull fracture. Battle signs, bruising behind the ears, a potential sign of a basilar skull fracture, or fluid drainage from the nose or ears, possibly CSF. And then we get into the abdomen and we're looking for rigidity and tenderness and distension. Remember, you need to palpate all four quadrants. And within extremities, it really is PMS, pulse movement sensation, are the things you're really wanting to look for. And then kind of detect your bleeding type. So bright red spurting, we're talking about arterial, dark red steady flow, venous, or just some slow oozing capillary type bleeding. Now, focusing on some abnormal findings. Focusing on some abnormal findings. So prioritize that problem area, so pay close attention to specific injuries or abnormal findings noted during the primary survey, monitoring for changes in these areas such as increased swelling. Intervention check, so confirm the measures taken to control bleeding are effective. So direct pressure, is the bleeding controlled? Dressings, are they secure and not saturated? And then a tourniquet, obviously appropriately placed, and maintaining bleeding control. And then within vital sign monitoring, we want to look for some patients with severe hemorrhage, reassess and document vital signs every 5 minutes during transport. We're looking at heart rate, we're looking at blood pressure, respiratory rate, O2 saturation. And then emergency medical care for bleeding and hemorrhagic shock. So always follow your standard precautions. So always PPE, treat everybody like they're sick, and one day when you take care of one, you'll be good to go. Always with these kind of patients that we're talking about, maintain a high index of suspicion for shock, especially in cases involving significant bleeding or trauma. So managing that external hemorrhage, We want to. There's a skill drill in your book 31.1 for proper hemorrhage control. So direct pressure, pressure dressings, tourniquet. We've talked about all of that. Hemostatic dressings, rapid transport, aggressive management. So we're still talking about the same stuff. Now from the nose, the ears, and the mouth. So indicates potential skull fracture or serious head trauma, so bleeding from the nose, epistaxis, or ears may signal skull fracture, can be associated with intracranial injury or cerebrospinal fluid leakage, requiring urgent evaluation. So don't block the flow, avoid obstructing bleeding from the nose or ears. This can increase the ICP or intracranial pressure. Cover the site loosely, so just a sterile gauze pad, light compression. Now, CSF considerations, cerebrospinal fluid considerations. So signs of a CSF look for a bullseye pattern on the dressing where the blood is surrounded by a clear ring, and you can actually test the fluid with a glucometer. So high glucose levels indicate the presence of that CSF. Managing nosebleeds. So cold compress, use gauze for pressure, monitor for underlying issues. So when we talk about that gauze for pressure, insert a rolled piece of gauze under the upper lip, pressing gently against the gum. What this does is it applies indirect pressure to blood vessels that supply the nose, aiding in bleeding control. Now sometimes it can be from a hypertensive emergency, or it can be just because they got a nosebleed. Maybe it's winter and everything's really dry, or they just get chronic nosebleeds. So talking about some other areas, apply nothing new, apply direct pressure, apply tourniquet if you need to, utilize hemostatic dressings is indicated by your local protocols, of course. Stabilize with splints if you need to. So whether you use an air splint or just a normal rigid splint, stabilize that affected area if it requires splinting, maintaining their body temperature, position the patient. So when we're saying position the patient, ensure that the airway remains patent and circulation is optimized. And I don't know what the local protocols are anymore. I know there's a lot of conversations about Trendelenburg positions, but whatever your local protocol is, you can consider Trendelenburg or however whatever you deem necessary. With a lot of these patients, you may want to utilize air support for this, so you may want air transport whenever you're trying to get these patients to wherever you're going just a little bit faster. Now, tourniquets. So severe extremity hemorrhage, most effective for bleeding below the axilla, so below the armpit or groin when direct pressure and pressure dressings fail. So typically a major arterial injury can lead to exsanguination in as little as 2 minutes. So you want to try to aim to apply this tourniquet within 20 seconds of identifying uncontrolled hemorrhage. Now there are some different types. You have a mechanical advantage tourniquet, so a strap and buckle system, or special operations forces tactical tourniquet, durable and designed for tactical use, easy to apply in high pressure situations. You've got the CAT, the CAT, you've got a ratcheting type system, and then a stretch, wrap, and tuck tourniquet or a SWAT tourniquet. Make sure that you understand your tourniquet, that's where you're at, whether it's here at school or whether you're at your service. But the steps for proper tourniquet application. So you locate your bleeding site, place your tourniquet about 2 to 3 inches above the wound, ensuring it's not over a joint. Tighten the tourniquet until the bleeding stops, then secure the device based on its specific design. And then write down the exact time of the application. And there's a skill drill 31-2 also. So monitor your patient when we're talking about these. Do not loosen or remove. One thing that I found in a study that I'd read, it seems like one of our biggest challenges is as you're cinching it down, your patient will let out a yelp, and it will be incredibly painful for them. And typically you need at least one more complete turn, maybe sometimes 2, to completely shut it down. So this is not a very nice thing, but it is a life-saving intervention. So it is not comfortable for people is what I'm trying to say. So here's all the kind of different ones that we talked about. Be familiar with yours and be familiar how to put them on. And unfortunately in this day and age, it's a good idea, especially if you ever decide to do any tactical things. However, a lot of places are using just the first responding unit as a tactical unit. make sure you can put them on yourself, which is a sad thing to say, but make sure that you're familiar with it to where you can administer it on yourself. And then we have some additional techniques, almost like, think about like, what you would do at the lake, or what the Boy Scouts maybe taught you to do if you were in the Boy Scouts or Girl Scouts. So talking about triangular bandages, maybe, and maybe this, maybe you're out on a truck and you use a tourniquet and you don't have any more, or it wasn't restocked, or your kit got left somewhere, or whatever. Lots of options to do when you're talking about tourniquets. So you can use a triangular bandage, or even just a wide strip of fabric as the base. And you wrap that material around 2 to 3 inches above the wound, avoiding the joints. Once again, tie a knot, then place a stick or a rod into the knot. Twist the stick or the rod until the bleeding stops. Once again, you gotta go pretty hard. And then secure the stick in place to maintain consistent pressure. Now you can use a blood pressure cuff if you have no other tourniquet options. So place the blood pressure cuff 2 to 3 inches above the wound. Inflate it to it's high enough until you are inflate the cuff to a pressure high enough to stop the bleeding, and then ensure the cuff remains inflated and does not deflate during use. So if this is something that you might do, you're definitely going to need to inflate the cuff. Shouldn't say definitely, I've never done this, but generally above systolic pressure, above their systolic pressure, or I would assume that systolic pressure would override the pressure that you're putting on it. So a couple of key points to remember: use a wide base. We're talking about special applications here. If something's not available, use a wide base. So ensure your improvised tourniquets are wide enough to distribute pressure and prevent additional tissue damage. Record the time, of course, monitor your patient, and then follow-up care, meaning getting them to the right person. Now here's a couple, next few are kind of specialized things, but junctional tourniquets for hemorrhage control. So what is a junctionalized tourniquet? Specialized device designed to control hemorrhage in areas where traditional tourniquets are ineffective, such as the groin or inguinal region, the axillary or the armpit region. So how it works, you've got a belt system. So you have this belt-like system. It's secured around the body to hold the device firmly in place. Then you have an inflatable compression device. So this pump initiates a pressure pad, which applies direct compression to deep blood vessels, effectively stopping severe bleeding. The nice thing about this particular device is you can use it as pelvic immobilization as well. So when it's applied around the hips, it can stabilize the pelvis in cases of pelvic fractures while also controlling the bleeding. Now, when to use for massive bleeding in areas where traditional tourniquets cannot be applied. So we're talking about, once again, groin injuries and armpit injuries. Make sure you follow your manufacturer's instructions. Make sure you're ensuring its effectiveness. Make sure it's secured, the bleeding is stopped, and then record your time as well. Placement locations when we're talking about tourniquets. So we mentioned it, but avoid joints. Never apply a tourniquet directly over a joint. So never apply it directly onto the elbow, directly onto the knee. Place it above the injury, so proximal to the wound. Material choice. Use the widest bandage available. We already mentioned that. Avoid narrow materials. Secure tightening, so make sure it's securely tightened to stop the bleeding. Do not cover the tourniquet with a bandage, so you want to be able to keep it visible, because while you can keep your eye on it to make sure that there's no little slow leaks. Make sure there's not a leaker there. And then hospital communication, so let them know you're coming and make sure they know when the time of the application was, because that's going to be pretty important. And then once you're out there, it's much like airway. The best thing is to not do anything with it. So do not loosen or remove the tourniquet unless you're explicitly instructed by the hospital staff or medical control. So why do these things matter? Well, correct placement prevents additional injury to the patient. It also ensures the tourniquet is effective, and it controls life-threatening bleeding. And then that material selection, it reduces the risk of complication such as nerve damage or skin necrosis. And then, of course, hospital preparedness. They need to make sure they know what we're coming with. So, fractures and bleeding. Broken bones can exacerbate bleeding and trauma by lacerating some vessels. They also damage muscles and tissues and disrupt the clots. So we'll talk about lacerating some vessels. So those bone fragments can tear nearby blood vessels, increasing blood loss. And then bone movement causes additional injury, compounding severity, talking about damaging the muscle and tissues. And then disrupting the clots, that movement of the fractured bone may break partially formed clots, worsening the hemorrhage. So the priorities of splinting, so immobilization first, properly immobilize, stabilize the fracture. Prompt action, so splinting should be performed as soon as life-threatening injuries, so we're thinking about uncontrolled external bleeding or even an airway issue, have been assessed and managed. And then benefits of splinting and bleeding control: prevents further damages. Immobilizing the fracture stops sharp bone fragments from cutting deeper into surrounding tissue or vessels. Reduces pain. That movement of that area can create more pain. And then, as we mentioned before, it supports clot formation. Now, air splints, I'm not sure if anyone's using them here, but in the event you go to a place that maybe is using them, you can use these as a pressure dressing. So air splint acts as a pressure dressing over the entire extremity, effectively controlling venous hemorrhage by providing consistent compression. Now, also I guess the original use for these was fracture stabilization. So they immobilize the fractured area, reducing movement and further trauma to those other areas. And then some key points, once again, monitor circulation. So we're looking for pulses, movement, sensation below the area or distal to the splint. And then inflation guidelines: 50 millimeters of mercury, which is adequate for controlling venous bleeding, but not sufficient for arterial hemorrhage. And then valve stem precautions, so be careful about those. And this is more rigid splints, traction splints, stabilized fractures, reducing pain and preventing further injury. I'm not going to go into this just because this is something you're already certified in. Should be good to go. Now, hemostatic injuries. We're talking about severe hemorrhaging. So hemostatics agents are designed to manage severe bleeding, particularly in an area where tourniquets cannot be applied. So we're thinking about inguinal wounds or maybe axillary wounds or armpits. Target area ideal for junctional wounds and irregularly shaped injuries where traditional methods like direct pressure alone may be insufficient. So how they work: agent adheres to exposed tissue, focusing its effects directly at the bleeding site. Now, some agents work by dehydrating the blood, thickening it to form a clot, and then others activate the intrinsic clotting pathway, accelerating natural clotting cascade through a chemical reaction. So always follow your local protocols. You may need to combine this with other methods, more than likely. So use in conjunction with pressure dressings or direct pressure. And then once again, reassess regularly. And then some common attributes. So lightweight and portable. Wound conformity, so conform to irregular wound surfaces. And then high pressure resilience, so they're effective in controlling from high pressure wounds such as arterial hemorrhages, where rapid blood flow might otherwise hinder clot formation. Safety and efficiency, so we're talking about tissue preservation, simple removal, localized effect, things like that. So these agents are designed to minimize damage to surrounding tissues, reducing the risk of complications like infection or delayed healing. Simple removal, it can be easily removed with minimal disruption to the wound site. And then it acts specifically at the wound site, preventing unintended systemic effects or complications. I know what you're thinking. We're getting there. We're getting there, guys. Hang in with me. Don't have long. So hemostatic agents and bleeding control, still talking about that. Impregnated gauze, so it's treated with proprietary clotting substances. The advantage to that: easy to apply directly to the wounds, highly effective in controlling severe bleeding, and safer and easier to manage compared to powder agents. However, there is a risk of emboli. So fine powder particles may enter the bloodstream through open vessels, potentially cause an embolism, which can obstruct the blood flow in critical areas. And then foreign material introduction. So, this powder-based agents, they introduce a foreign substance into the wound. It can complicate wound healing, and it can increase the risk of infection if not properly managed. But these are safer and easier to handle, more commonly used in both field and hospitals. But again, always follow your protocols and how to do it. Not just when, but how to do it as well. So in the event we're talking about wound packing, we're talking about junctional, effective for junctional bleeding. So ideal use, areas where tourniquets cannot be applied, groin wounds, underarm wounds. Blood absorption, how it works. Wound packing materials absorb liquid from the blood, concentrating the natural clotting factors at the site of bleeding. This process enhances the body's ability to form clots. So I know a lot of this seems like we just keep repeating it, and you're right, we are. However, it's because some of these things work very similarly or exactly, just in it, we're just talking about a different area of the body. So enhanced clotting with hemostatic dressing. So we're talking about kind of the chemical action. Hemostatic dressings do more than absorb blood. They trigger chemical reactions that accelerate the clotting process. So this combination of physical absorption and chemical enhancement make them highly effective for severe bleeding. Managing internal hemorrhage. So primary management goals: want to treat shock, focus on maintaining perfusion, and we want to address those shock symptoms promptly through O2 administration, fluid resuscitation, as guided by your local protocols, and patient warming. Limit the movement, rapid transport, and surgical interventions, we're wanting to get them to the right people at the right time. Restricting their oral intake, so nothing by mouth. IV access, so place at least one 18-gauge IV catheter for fluid. If time permits, establish a second IV line for redundancy and enhanced access. So here's some fluid bolus things. Administer a 250 ml bolus of normal saline or LR solution to address hypoperfusion. Avoid over-resuscitation to prevent increased bleeding. So depending on your protocols, of course, but what is recommended is something called permissive hypotension. So it may be advised in some trauma cases. What happens is we start flooding people with these fluids, and it causes the body to work harder. Also remember, the fluids don't carry oxygen, and also, just as importantly, that high pressure starts to blow out those clots. So permissive hypotension, typically somewhere around 80 to 90 on a systolic, is what's being recommended by trauma surgeons, or at least most. Warm IV fluids if you have the chance for that. Comfort measures, when we're talking about pain management, so appropriate pain management. Maybe you're lucky and you have things like ketamine for a pretty sick person, or if you don't, you just have some fentanyl. Make sure that you're trying to use some appropriate pain meds for this. Immediate transport, course serial vital signs. If signs of shock are present, we want to get a little aggressive, so provide rapid transport while addressing signs of hypoperfusion through oxygenation, fluid resuscitation, and worming. Remember those three key components that we talked about when we talked about that triad of death. And then standard precautions. How many times can we say it? All the things, do all the things. Control external hemorrhage, so direct pressure or pressure dressings, tourniquets, hemostatic agents. Make sure that the airway is open and patent. Patient positioning and reassurance. So as you can imagine, someone that's all broken up or someone that's burnt up or whatever, there's going to be a lot of anxiety and stress. So if we're able to kind of reassure them that we're doing everything that we can, that's going to be really good. That's where things like ketamine are really handy, because then they don't seem to care quite as much that they're so broken. But restricting our oral intake, immobilizing and splinting. So you can use a backboard to stabilize the spine if a spinal injury is suspected. Splint the fractures, prevent further injury. Remember, backboard's not just to splint a patient that you may suspect a C-spine injury. It might be a really good way to move somebody as well. We're getting there. I've only got a couple more. Hang with me. So we talked about 1 or 2 peripheral IV lines, warm fluids, 250, closely monitoring the patient's response. So we want to, as I mentioned, we want to maintain in that low normal range of blood pressure. We want to avoid disrupting those clots that are trying to form. We want to use that permissive hypotension if we have the ability to. Initiate blood products early, and it's not controversial. It's just, I don't know the right word for it at the moment, but it's something that only a few places have. And I say a few, I don't mean nationally, I just mean locally. And there's not a lot of people that have the ability to use blood. But in the event that you're at a service that has is the ability to use blood products, that's going to be really good. A couple of reasons. One is it restores oxygen carrying capacity by putting in those red blood cells. It also improves the clotting ability with the plasma and platelets that we talked about earlier. And I believe our last one, if you can hang with me, we're there. So continuous ECG monitoring. Look for dysrhythmias. When people are in shock, you can start to see some things because there's a lot of hypoxia going on. So hypoperfusion can affect the heart. Hypoxia, low oxygen, can affect the heart. You start to see some weird changes in your rate and rhythm on the monitor. Assess your mental status, so your LOC. Detect early signs of deterioration. So a declining LOC often signals inadequate brain perfusion due to hypovolemia or shock. That's going to be a really big component you need to pay attention to, is those changes in LOC with these kind of patients. So, we're talking about like your AVPU, AVPU, or your GCS. Track your vital signs, so your pulse, your blood pressures, your respiratory rate, O2 saturation. And let's see what's next. There we go. That's it. All you have left is me. I apologize about that, but it is what it is. So we'll see you next time.